In today's episode of 26 Minutes with Dr. Warren Siegel on the Zormed Show, we'll delve into learning more about pancreatic cancer and the complexities of this very challenging disease. We'll explore the latest advancements in treatment, understand the vital signs to look for, and discuss the importance of early detection. I'm your host, Dr. Warren Siegel. Joining me today is Dr. Christopher Chum, a renowned expert in the field of oncology with a special focus on pancreatic cancer. Dr. Chum, thank you so much for coming today.
Hi, thank you. Thank you for having me today.
So tell me a little bit about yourself.
So I was born and raised in Brooklyn. I received my training through Chum, and I did my training there actually at Coney Hospital, and my fellowship training as well too in gastroenterology. A large part of where I am, we have the fellowship program, so we have teaching is an academic component for these things as well too. I do a large part of advanced stage procedures in our institution, and we have a large network affiliation that deals with most of the hospitals, one of them being North Shore, Lenox Hill, for these things as well too that we manage.
So you have a particular area of expertise, as I mentioned, is pancreatic cancer. Can you explain? What is the pancreas? I mean, I remember, as a child, where your heart is, and you learn where your lungs are, and where's your pancreas?
So the pancreas itself is a very important glandular organ. It's located more so in the upper abdomen, right behind the stomach over there. A very important part of digestive function. And it has several features. It releases enzymes that aid in digestion, also a hormonal system. Some hormones you might recognize, such as insulin, that deal with blood sugar metabolism for these things. But as you can understand, that when there are defects or problems with these organs, they can lead to things such as diabetes, they can lead to pancreatitis or chronic bouts, they can lead to chronic pancreatitis. And obviously one thing that we get very concerned about is pancreatic cancer.
So pancreatitis is an infection around the pancreas?
More so inflammation to the pancreas, not really some more infection. Can infection occur with pancreatitis? It is possible in severe states for these stuff. But when we think about inflammation and trauma to that, there are many different etiologies, such as smoking, drinking, for these scenarios for that, or as we know, common causes of stone-related disease. But when we think about chronic insults, that means frequent insults to the pancreas that occur, just like when you have a scab on your hand, inflammation occurs, scar tissue can develop inside the pancreas itself. That itself can be a risk factor for pancreatic cancer.
So let me back up. Everybody is born with pancreas, right? And as we get older, as children develop, do they get these problems, or is it normal to have this kind of inflammation you're talking about?
No, it's not actually. Not everybody gets pancreatitis. There are risk factors for development for pancreatitis that may occur for these. And not everybody has risk factors that can develop into cancer and so forth for that. However, there are risk factors that may potentially cause or put you at risk for developing these things, such as pancreatitis.
So what are those risk factors?
So risk factors include, for example, heavy alcohol usage, drinking, obviously stone-related disease, such as gallstones. They can come in more common causes, usually gallstone-related, alcohol-related for these things. Other causes also include, for example, medications that can be caused. And all the things that we may not necessarily know as modifiable risk factors can also be genetics and the potential cause for later development.
So you mentioned alcohol. You say drinking. How do we say, or how do you decide if I'm drinking too much and more likely to develop problems with my pancreas? Brandy drinks,
So too much. So it's not necessarily the amount of drinks, but a lot of times people come into the heavy insult of developing pancreatitis come back. And when patients get admitted to the hospital, or they get evaluated in outpatient setting at the pancreatitis, and they can evaluate by several weeks. Abdominal pain, then we do a blood test and a combination of imaging tests. We do out of these three criteria. If it fills a diagnosis for pancreatitis for these things. Now, obviously, stones being a little bit more common, but when we think about alcohol related for that, we tend to think about, okay, if they're drinking excessive, okay, let's say somebody comes in drinking with a liter of vodka per day, it's upcoming as an insult for them, having inflammation that occurs in the pancreas for them. Then maybe one episode for them. But what we mean is that repeated episode that keep occurring again. So alcohol being the trigger, causing the pancreatitis event, causing trauma to the pancreas. repeated at the cells over the year or cell years on 4, and that's where we get chronic inflammation that can occur to the.
So what are the signs and symptoms that I might have a problem with my pancreas?
So the few things that we should be concerned about when we think about pancreas is obviously if we think about suddenly development of diabetes, unusual control of blood sugar, it can occur with these things as well too. Digestive-based problems, patients they feel offensive bloating or abdominal bowel movement that can be occurring as well too for these type of patients. But when we think about just the in itself and we think about where it's located and its functions as well, so we talk about digestive-based purposes, we talk about hormonal-based purposes, then we also talk about mass-based purposes. That means that when inflammation becomes very big and they develop the potential risks of such as cancer itself, then we should look for some symptoms of, let's say, pain, and pain that can be severe. It can radiate to your back or to your sides, and it's unrelenting. It's a kind of a pain that's more pancreatic origin for these things. A little bit more concerning is when patients start to lose appetite, they start to lose weight, or they may develop something called jaundice, which is like a yellowing of the skin or the eyes. These are a little bit more concerning in more severe states where we might be concerned that they may develop cancer that might be associated in the pancreas, these things. But do be aware of that, if we think also about pancreatic cancer, they may not necessarily present with pain. Sometimes pain may be a late presentation of cancer in itself for that lead to pancreatic cancer. We would look, for example, if they have clay-colored stools, it would be pale. Do they have dark-colored urine that may occur for these type of patients? That means that the bile is not being properly processed and excreted into their GI system, hence why you get the clay-colored stools that might be developing. So these are just some of the signs and symptoms. And if we think about cancer as well, do they have recurring blood clots that may occur in the system over there? Is there family history of cancer in the family, including pancreatic cancer? Is it direct leads, mother, father? Very important things to talk about. Are there certain risk factors into cystic fibrosis that patients may have these that may put them at risk for pancreatitis, not necessarily pancreatic cancer as well? But these are all important things to acknowledge, put into place. And if there are concerns about this, it's very important to obviously see your doctor, talk to the physician, and ask them, hey, maybe I have something wrong with my pancreas. So, what can I do to get this checked out, to have this looked at? And what are tests available? What imaging tests are? What tests is, what's going on?
Wow, that's a lot of information. So let me see if I got this right. So everybody's got a pancreas. There are certain things like excessive use of alcohol that can put you at risk for developing inflammation of the pancreas, which is in the upper abdomen behind the stomach. And if you have pain, changes in your stool, or loss of appetite, losing weight, you should get it checked.
Right.
Can any doctor check this out, or is it something that we need to go to somebody like you who specializes in the pancreas?
And I think at the very beginning, it's very fine to speak with any physician in the medical field. From the get-go, you should speak with your general practitioner, your medical doctor, your primary care doctor that comes to the place, and discuss with them what are the symptoms that you're experiencing. Because when you think about the pancreas, and obviously the thing that we get concerned about the most is pancreatic cancer, and it's such a diagnosis that's very difficult to diagnose for that. There are a lot of symptoms that can be vague. Sometimes pain in the stomach could be many things. It can be an ulcer pain, it could be just gastritis, bloating, functional causes for that. But it's a constellation of symptoms that put into place where, okay, the physician can kind of piecemeal these things, especially if there's family history. They say, should we walk this further by approaching maybe an imaging test? We can stop that first. And then if we pick up something abnormal, then we may refer to a specialist from there. Or sometimes primary care physicians, considering a strong risk factor in family history, they refer from the very get-go to have these evaluated. Now, the reason why I think it's very important and why we want to be on top of diseases of the pancreas is that the end origin of things that when we have chronic inflammation and damage is pancreatic cancer. And pancreatic cancer in itself unfortunately, it's something that we find very late. And the survival for this is really, for resection, is really only about 15 to 20% when it's discovered for that. And the sad part is that the 5-year prognosis, even when resected, it's still fairly poor, quoted about 5 to 20% actually, and overall survival rate about 6%. So I guess the question is, we can determine the findings a little bit earlier. Now, overall, the cancer itself is maybe about, the eighth most common cause for women, 10th most common for men. But the most important thing to recognize is that it's the fourth leading cause of cancer-related death, if not the third coming into 2024. And why is that? Because there's not really great screening modalities, and treatment itself is still being explored, but we're trying to find out what's the best way of how we can manage and treat these things before they develop into cancer. Can we find a precursor to that?
So this is a program about health. And although I don't think you've said it, but I'm going to put some words in your mouth. We have to stop drinking alcohol.
Not just alcohol, smoking as well.
Oh, smoking too?
Smoking is an all-time big risk factor for many different cancers. Almost it has a big-time amplifier for pancreatic cancer itself.
That's interesting. So I always associate, smoking, with cancer of the mouth, the lungs, but smoking increases the likelihood you'll get pancreatic cancer as well, right? And alcohol. Any other risk factors? You mentioned for genetics. I can't change my family background. Is there anything that I can change to decrease the likelihood of getting pancreatic cancer?
Yes. So there's a few things that come into place. One is when we think about cancer with pancreas, I mean, the overall incidence of age is really more of the older generation. So we're talking about more between age 60 to 80, really up to age of 50. And it is more common, kind of more so in men rather than women, these things that are there. Now, the modifiable risk factors that we talked about is certainly cigarette smoking, alcohol usage, but there are a few other things that come into place, such as our diet, right? So if our diet is low in fiber, high in fats, high in meats, there are links of obesity coming into place. Diabetes in itself is also considered a risk factor related to that. And exposure to heavy toxins and work to these and when we talk about genetics it's very important to explore, because certain genetic conditions, let's say somebody may have breast cancer, for example, and they may never think about the pancreas. And that could be someone's family, mother or grandmother from their lineage for that. But if they carry the same gene, they may not necessarily have breast cancer, but it puts them at an increased risk for pancreatic cancer. And these are some of the patients there that it's important for them to know they have these genetic risk factors over there, because they actually qualify for a screening program. And that's where screening actually comes into place, where, our societies don't really recommend it for the general audience, just based on the overexposure, the costs and risk benefits, and also the anxiety that occurs, because there are also a lot of false positives that occur with tests and flow too. But our societies do have good guidelines that come into place to suggest that patients who have a genetic predisposition, these patients would qualify. And based on some genes, there are some patients who may undergo screening as early as 30 years old, actually, to have this validated, so that we can find this early before it can develop the cancer. And as we see, the 5-year prognosis is even after resections, or we can intervene sooner for this.
So when we talk about screening, are we talking about blood tests? Are we talking about the X-ray? What you're really talking about screening?
So a lot of times when it is discovered, when we talk about pancreatic cancer, oftentimes besides from the symptoms, your physician will order likely a test, which is an imaging test, and then includes, for example, such as ultrasound, a CAT scan, or MRI. And sometimes they may ask for something that might be a little bit more invasive, such as an endoscopic procedure, such as an endoscopic ultrasound, if they'd like to get some tissue from these things there. So based off of the initial, it's an imaging characteristic if there is a lesion or a mass to pancreas for there. And when we talk about screening, we generally recommend that kind of purposes. So according to the societies that come into place, when we talk about screening for pancreatic cancer and those who have genetic predisposition, it would say either a CAT scan or an MRI that might come into place maybe annually for these things. But the age is dependent on the type of genetic condition they have. Who in the family has had that as well too. When we talk about blood tests, however, there is no effective screening blood test as it stands right now. There are biomarkers in investigation, but not yet approved in the market. There are tumor markers that a lot of people may be familiar with. That they go online, they look up a tumor marker, and it says a tumor marker called CA19-9. Now, when we talk about tumor markers, it's very important to take that also with a grain of salt. Tumor marker, which is a blood test, is not a screening test. It is non-specific. And at the same time, there are a lot of benign conditions that can also cause an elevation for that, such as gallstones, thyroid disease can cause an elevation of CA19-9. So you can imagine that if you order this and somebody has elevated, and they don't have any of the risk factors, and if they have just dyspepsia or they have ulcer-related type pain, they're going to go with Schulho tests, Schulho referrals undergoing. So it becomes costly. They get very anxious. They get scared. So, that's one issue when it comes to blood tests. But as you mentioned earlier about screening, and we talked about genetics, there's another thing that's very important to take into mind is pancreatic cyst, which is something a little bit more common, and it's a little bit more common now because our technology is getting a lot better. We're able to pick these things up, and they're thought majority of the time incidentally for these things. But these are the type of patients where not so much genetics, but pancreatic cysts themselves do follow a role to have surveillance imaging for these, because they can be a precursor and a cause for pre-malignancy. A cyst that is initially benign, but can potentially grow to become something that is malignant down the line.
So how would I know I have a pancreatic cyst?
The problem with these things, pancreatic cyst in itself, there is no modality to say to the general audience, okay, let's screen them and do an imaging test for these things. They're often found incidentally if somebody comes with abdominal pain to the ED, emergency room, or a physician may order a test, and they find these incidentally on the imaging test is over there. But for the most part, they may be concerned when we have some of these signs and symptoms that we talked about earlier that may warrant a test, such as the weight loss, the jaundice being one of the red flags where you turn very yellow, the eyes turn yellow, the abdominal pain with these things as well too, a change in your stool color. These are all signs that something is going wrong in your biliary system and where the pancreas is located, and things are not flowing very freely over there for that and for digestion as well too. And that's where it will prompt the physician to maybe order for tests and order imaging test evaluate over there. But as it stands, there is no formal screening for it. Okay, you at this age, you do a CAP scan to see if that pancreatic cyst. No. If it's found, however, we have guidelines that come into place that should be surveyed, and based on certain sizes, where we may do a dimension to sample these things, or based on certain sizes of appearance, it may actually go into surgery just to prevent the potential risk that it can develop into these things.
Wow, I'm getting nervous here. So what I've heard so far is I have to eat right. I have to not eat a lot of fats, not eat a lot of meats, not drink a lot of alcohol, not smoke. If I have a family history of, I think you said cystic fibrosis, that puts me at higher risk.
Family history includes, what I mean by family history is that there's a family of pancreatic cancer.
Pancreatic cancer.
Cystic
Anybody in the family, mother's side or father's side who had pancreatic cancer, that puts me at risk.
And that definitely puts at risk. It puts at risk where you have to get genetic screening first to see if there's a genetic component that is hereditary to make sure that you don't have this. Because if you do have this, it puts you at risk of pancreatic cancer. But the family history, meaning that obviously having pancreatic cancer is very important, but the family history of having other types of cancer, genetic syndromes, such as Lynch syndrome, for example, colon cancer, French cancer, ovarian cancer. These syndromes have risk for other types of cancers that are available. And having the genetic predisposition for this, meaning you're positive for this gene. You went for genetic testing, you went for that because your family has this, maybe your family had testing for that as well too. So you want to have tests for yourself and make sure that you have this so that you can have an early screening protocol. So it means that not just for the pancreas, if you have risk factors for colon cancer based on a certain type of gene, then you may undergo colonoscopy earlier or an endoscopy earlier for that. And one of these things where we're kind of lacking or falling behind is catching on pancreatic cancer. So if we know that in these genetic conditions, they have a higher risk overall of developing into pancreatic cancer. For example, like Peutz-Jeghers syndrome, for example, we warrant an earlier evaluation before it can potentially develop, so we can catch on it before it happens. And the problem is that when we catch on it, when the symptoms happen already, oftentimes they're too late.
And you mentioned genetic testing. Is that a matter of, again, a blood test, or what does that entail?
A combination of things. So when we talk about genetic testing, one is if the family already has an underlying cancer, they may have already done genetic testing from the tumor itself, so the tissue itself, and they check for genetic testing for these. Otherwise, then they can be screened from saliva, can be screened also for blood tests from these. The important thing is talk with your medical doctor, and then you may have to see a geneticist as well too, to see if we can get a pedigree of things, and see if it can be linked also to any potential genetic tube that we may have out there.
This is fascinating. An organ that we don't talk much about. In fact, I would venture to guess most people don't even know about the pancreas. How did you get so involved in this? What is I think about pancreatic cancer that drew you.
I said this specialty. It's such a complex field in itself. And we're trying to understand a lot about this actually, because a lot of our treatments are still evolving, and at the same time, diagnosis is also very poor and very difficult. Sometimes obtaining tissue can be very difficult as well too in stock cases. And it presents some sense of the challenge, right? And I like that. I like to be part of it, or also it doesn't benefit for our patients where we can treat them, we can diagnose them, we can also alleviate some of their symptoms, such as the jaundice and the pain with our endoscopic-based procedures. But we work hand in hand also with surgical oncologists. We work also hand in hand with our oncology doctors as well to see if we can get a rapid diagnosis, where sometimes when it's not too clear, right? So the imaging tests are not too specific for a mass, but we have the signs and symptoms that are very impairing. Tumor markers may not be elevated because, again, they can be normal in 10% of cases of patients who even have pancreatic cancer there. And this is really where it comes into place where, you have to take a deeper look, and you will may have to do an endoscopic ultrasound to evaluate pathology over there. And sometimes if imaging is very characteristic, we may say, okay, let's just proceed with surgery then these expenses. So it becomes a big multidisciplinary discussion and an involvement in the process of that. It makes it very invigorating. I love it, and it certainly helps the patients, helps our community. It provides access, and most importantly, it's a fast access to a diagnosis, a treatment, and a plan going forward. And it's not just for the patient, it's also very important for the family. Once we diagnose pancreatic cancer, and especially age, then it's very important to reach out to the rest of the family members as well. Like, are they ours? Is there a genetic component for this? Should they be screened as well too? And this is where something we forget is a registry that comes into place, and that really can pick up things more objectively. Family has this, family has that. Okay, did we test for this gene or not? And then, what kind of services can we offer to the patient and family?
Okay. So if someone has pancreatic cancer, we've made the diagnosis, you said the prognosis is not very good. What are the treatment options?
So the most important thing for treatment is staging. Staging, what it means is it's a way to allow the physician to determine how advanced this cancer has developed. And what is cancer in particular? It's when the cells obviously grow to a very abnormal number, and they can invade nearby organs as well too. Or it's obviously called a mass, hence pancreatic tumor, pancreatic cancer, pancreatic mass of that. But the staging is very important because if it has invaded other organs, it may not be a candidate for surgery. And the only cure is surgical resection. But there are some instances where they may be foreign. So that means that it may have some degree of encasement to arteries or nearby, but not completely prohibiting them from surgery. But they may undergo what is called neoadjuvant chemotherapy or radiation. And the purpose of these things is to kind of help shrink the tumor to make them more favorable candidates. Because the concern is that there may be lymph nodes that are possible, micrometastases around the area for that, to make them really good surgical candidates. So they would be reevaluated at time frame later down the line. But during that time period where they may be potential candidates and may undergo interventions, again, such as an endoscopic ultrasound to get tissue, or they may undergo something called another endoscopic procedure called ERCP, which allows stenting for us to occur for the bile so that the bile can freely flow and not get obstructed by the mass of the pancreas. So we'll alleviate some of their symptoms, but also we can also treat pain, which is one of the issues as pancreatic cancer evolves. So we can try first with oral, or we can try also with injection medications through a nerve, such as a ciliate block as well too. And and also now when we talk about more advanced-based cases, then in these scenarios, then surgery is not the option. Chemotherapy is the way to go for that. And in the process of treatment, it's not just the surgery and the chemotherapy, but it's a big emotional component, not just for the patient and the family. So it's very important to, one is educate as much as possible, provide a lot of information, but provide services as well, such as palliative care to help assist with the family. Are there any traditional tools that they may need for that? And then especially when you think about more advanced-based cases, such as when they become metastatic or when they spread, those services such as hospice care, what can we do towards when we think about it in preparation for end-of-life care for that?
I'm actually wondering, what about those families who someone in their family has had pancreatic cancer? You mentioned screening. What else should they be doing? And how scared should I be if somebody in my family has had or has died from pancreatic cancer?
For the most part, it should not scare you where you cannot function in life. I think it's very important that you do have a good family history in the place. So if you know that somebody in the family has had pancreatic cancer, then we talk about, again, one is getting that scrape. So let's ask, hey, did we ever find out, was there anybody else that had that in family? Is there a direct generational lineage for this? And obviously try to write this down in the chart. Were there any other cancers as well that come into place? And then it wouldn't hurt also to get a genetic screen as well. I would certainly see that's put you at risk, and there's a serum that is missing in that component of things. But we should avoid some of the modifiable risk factors that we had before. When we talked about cigarette smoking being an all-time risk factor for many different cancers. Alcohol usage in itself. We talked about obesity and diabetes as well too. Obviously, exposure to certain toxins and certain work environments involved for that. So those are things that are modifiable for that. If you find that, for example, incidentally, somebody in the family, not in the family, but if you have testing and somebody told you before you had pancreatic cyst and nobody really followed up on that, maybe you should follow with your physician to talk about that a little bit more. But when there's history, family history is very important because genetics plays a large part, that's at least 10 to 11% for the cause and risk factors for that. Is really run a list and really ask your medical doctor about that and see if you can get a genetic screen for yourself. Because there's important fun for not just you, but if you have children in your family going down forward as well.
Fascinating, and thank you so very much. And that brings us to the end of our program today. We sincerely thank you for tuning in and learning alongside of us. For more information about our show, please don't hesitate to call us at 718-510-2103. Stay updated and engaged with South Brooklyn Health by visiting our website at www.nychealthandhospitals.org/South Brooklyn-Health. This broadcast was proudly brought to you by Brick Media in partnership with South Brooklyn Health. Until we meet again, stay informed and please stay well.